Do not take them with you, because I would like to use it to actually craft the plan. All right, this group, tell me, what was your health disparity?
I'm Michael Spring, speaking for this group. The health disparity that we talked a lot about, it's one actually I don't think I've heard yet today, and that's oral health care and dentistry. That there's a significant disparity in the community based on socioeconomic factors, and we also think significantly because of race. In terms of the interpersonal bias issues, we think that it's likely, although we don't have the same sort of anecdotal evidence, we think it's likely that some of the same issues that we've heard discussed with visits to physicians' offices are likely the case. But where we really see it as a problem is in the structural and institutional side, because in the issues of oral and dental care, typically there's a large, even larger uninsured population, and those who are Medicaid eligible cannot find dentists that are willing to accept Medicaid patients. And we think that that's unlikely to change unless there's some structural component, some structural change from the government or on the reimbursement process to entice, if not compel, dentists to accept those patients. In terms of the institutional side, we talked about locations of offices and clinics, and again, typically those are not in areas where you have lower income patients, particularly minority communities, minority areas, and we think that, again, is largely a product of economic issues and ignoring an underserved population, and not believing that those are patients that are worth serving because they're not going to be able necessarily to pay or to be compliant with the instructions that they're going to receive.
Okay, thank you very much. And that is just like, as we talked about, right, there's a lot of issues here, but you can see how we don't talk about this. We don't talk about health disparities in a way where we actually look at how the healthcare system is perpetuating this. And so this is a good example of dentistry, as you said, right, the institution, but also the structural, right, in the sense of you get it if you have the ability to pay. And I cited to a story where a young boy, who I think was 8 years old, didn't go to the dentist. And instead, when he got the health care was when he had a brain tumor, and then we spent lots of money, right? And so we don't give care preventative or at the point where you need it. We give care in the emergency room, which is not the way to do it, right? So thank you very much. We are going to move out of the way, and I will be running around and grabbing your forms just so that we can keep them. Tomorrow, as you come, there will be more forms. Again, write your name in so we can keep track of it and actually have an action plan. But at this time, I would like to bring up Professor Gwendolyn Majed, who is an associate professor of law at Cleveland State University. And again, not to offend anybody else, shortening up the bios, everybody's esteemed has worked in this area. We really appreciate you attending. Thank you. There we go. Is this the correct one?
Oh, that's not me.
We have David going first.
Oh,
David is first.
That's right.
Okay, so I'm going to do like a very abbreviated introduction of the fine panelists here. I'm delighted to be here. I've served on panels with some of the panelists. I've cited some people's work, and we are all people who are interested in making Title VI work better to help reduce healthcare disparities in the United States. So Professor Smith was the keynote speaker this morning, and the key thing I just want to highlight for you is that he has a doctorate in health service research, and he's been the recipient of funding from the Robert Wood Johnson Foundation about the history and legacy of racial segregation in the United States and its impact on healthcare. After Dr. Barton speaks, then we will hear from Attorney Celeste Davis. She is the Deputy Regional Manager for the Office of Civil Rights for the 5th Division of the Department of Health and Human Services. And so that department is responsible for enforcing Title VI in the Region 5 area. And so she's going to talk about some of the cases that they have had and some initiatives that have been designed to reduce healthcare disparities. After Attorney Davis speaks, then we're going to hear from Professor Dana Matthew. She is a professor at the University of Colorado Law School, where she teaches numerous health law classes as well as evidence. She was an associate academic dean there, and she has written numerous articles about different legal laws that can be used to reduce healthcare disparities in very creative ways. Fraud and abuse laws, property laws, and today she's going to be talking about her recent work looking at implicit bias and how we can change Title VI to recognize that, which is definitely something we need to be thinking about. And then our final speaker is going to be Professor Sydney Watson from St. Louis University School of Law. She has worked on health law and healthcare access issues her entire career as a legal services lawyer as well as a law professor. And she has worked on Medicaid issues. She actually was one of the professors that wrote an amicus brief to help the Supreme Court decide correctly, which they did not do, how to interpret the Medicaid program. And she's also been thinking about how the Medicaid program can be used to help disabled people, which that is part of what they're supposed to do, but she's thinking about creative ways to do that. And her contribution today is to look at the civil rights provision that is in the ACA and what it's designed to do and how it's going to fill in gaps of Title VI. So we have 4 distinguished panelists that are going to give us different aspects of Title VI, and it's going to be phenomenal. Dr. Smith, would you please come up and start?
Yeah, I want to first connect 3 dots that sort of occurred to me from the other discussions that we've had. First of all, we didn't used to talk about disparities. We talked about racial and ethnic differences. The first time the term disparities came up was in, I believe, around 1990. And the implication of using the word disparity came directly from Title VI, where we talk about disparate treatment and disparate impact. So the implication of using the word disparities, although I heard in the last panel there are people who want to change that now to inequities because that makes it a little bit clearer, but disparities really implied that it wasn't the fault of the individuals in terms of either their bad behavior or their genetic makeup that made the difference. It was a system, and it was injustice in the system, and that's why I think we changed from using the word differences to disparities. So if you want to go the next step and talk about inequalities, that's fine, but I think the first step was a remarkable change in the discussion that had happened before that. The second point I want to make, I recognize that Title VI was passed, as well as Medicare, under the direction of Secretary Celebrezzi, who was for many years mayor of Cleveland before he became secretary. So there is sort of a kind of a neat idea to have this session here in the home of somebody who had done much to pass the Civil Rights Act and also to try to help with the early stages of its enforcement in the Medicare program. The third thing I want to mention to you is that presentation, although somewhat abbreviated, is going to become a movie. And we have a nice grant from the National Endowment for Humanities. We have a Hollywood director who actually used Haley Berry in one of his films, and Haley is also a Cleveland native, so that's kind of a neat connection as well. And hopefully it will come out next year or during the year of the implementation of Medicare, and you will see it on PBS and maybe in some other movie theaters. And it has all the stories that I wasn't able to tell this morning. If you're interested in some of those stories, send me an email, and I'll send you a 60-page, single-page paper that has a lot of the stories in it. I'd be happy to share it with you and get some of your ideas. I want to talk very briefly because I want to get to the lawyers on the panel. So I feel somewhat intimidated up here, just being a sociologist, historian. I'm not quite sure what I am anymore. And I want to just talk very briefly about the past of Title VI, the present, and what I envision as a more hopeful future for it. Okay. I want to talk about the beginnings, the birth of Title VI, because after Title VI was passed, nobody quite knew what they were how it should be enforced. How are we going to go about doing it? And there was this very, and HEW really fumbled the ball for about a year. You know, they couldn't quite figure out, and they didn't have the staff to do it. I didn't know other things. And then in the fall of '65, under guidance of Hubert Humphrey, the president said basically, yes, the agencies responsible for programs should be responsible for civil rights compliance. And we're not going to put it up in some office somewhere as a separate function. It should be a part of the day-to-day work of our entire agency. And then the new Secretary Gardner, who came in a few months earlier, was faced with a problem. He actually had many of the people in the civil rights movement sitting in his office in December. And so that probably stimulated him a little bit to try to think about this issue a little bit more. And he said, look, the key to adequate staffing is to say we are a civil rights organization. All of HEW is a civil rights organization. We are going to do this work, and we are going to make, we'll put the staffing to work as necessary. And so we'll assign all these people, and that's the way we're going to do it. And then, of course, LBJ had the right idea. He said, basically, he got all the people, all the hospitals together 2 weeks before the beginning of the Medicare program, and he said, we're not going to lock the door after the horse has left the barn. You're going to desegregate the hospitals, or we're not going to send you any money. Okay. Let me, and I call this desegregating enforcement. Other people will use the word decentralize, but I kind of like the word desegregate. We're going to desegregate. We're not going to segregate this function of getting compliance in a separate office, separate from all the other functions, which kind of defines it as being somewhat inadequate in terms of doing the task, because you're going to have to get all these other organizations to do it. So if we just segregate performance, it's a little less politicized, it's decentralized, a little harder for senators and other politicians to nail people for not doing the right thing, as happened in terms of some enforcement related to Columbia University. Those most familiar with the groups that are receiving funds are the ones that are going to be most responsible for doing that. And from that, you get clearer guidelines. You're able to spot problems. You're able to do a better job of designing plans of correction that make sense. And I think that was a good way to go. I would add that everybody bashes the Office for Civil Rights and OEO and OEHO, the Office for Equal Health Opportunity, but recall that this was the only gatekeeper. We delegated the function of quality improvement to the Joint Commission of Accreditation of healthcare organizations, which is basically run by the providers. We delegated the function of payment to these fiscal intermediaries, which were primarily Blue Cross plans, which were the creation of the hospitals. And the only place where we had a public gatekeeper that was concerned about accountability to the public as a whole was in the civil rights area. And the problem, of course, with it is this decentralization worked too well. It was too effective. Senators and congressmen started screaming, "What the hell are all these people doing? I thought it was only an office of 5 people, you know? I thought we controlled it." And they were having surveys, they were having all these people come, and so finally they said, key appropriation senators said, if you don't centralize this function, we're going to cut your budget. And finally, yeah, they dragged it out for another year. They stalled a bit, but finally they had to centralize it into an office. And with that process of resegregating the civil rights function in HEW, it lost some of its effectiveness. Okay, you may not be able to, this is sort of a blurry photo, but this is the first picture of the new centralized office for civil rights. And first thing you'll notice about it is it's all white men. And the other thing you might notice about it, there's a young guy, wet behind the ears guy, Leon Panetta, who is the director of this office. It was his first job in the federal government, and before he became head of the CIA and the Defense Department and got a reputation for being a tough guy. And he lasted about less than a year. And the way he was fired was rather telling. He was fired from the Senate floor. A congressman, a senator, I believe it was Senator Russell, got up on the floor and said, "I understand that Leon Panetta has submitted his resignation." And it became a headline in the local paper. In the meantime, the White House is calling HEW secretary to find out, did he submit a resignation? What's going on? And Panetta was calling the secretary and calling the White House to try to find whether they'd asked for a resignation, and they hadn't. And so finally, everybody figured that we didn't want to mess with Senator Long, and so if he wanted to fire the director of the Office of Rights, the press secretary for Nixon announced that he had submitted a resignation and it hadn't been accepted when he hadn't even written it yet. And he left. So that was kind of a telling kind of change in terms of the atmosphere, in terms of this whole effort. Okay, now that's the past. I want to talk about the present, and then I want to get to a more hopeful future. We've got about $1 trillion public dollars going into our healthcare system now, which should be subject to Title VI. Every year, $1 trillion is now flowing in. We have no data for tracking compliance. This was one of the first things that was pointed out after the passage of Title VI. We should have a way to do this. We shouldn't have to rely on going out on surveys and doing compliance reviews. We should know what's going on. We should have people submitting this information so we know whether they are. Granted, there's some things you can only do in terms of field investigation, but having the data is a hell of a lot better than just responding to complaints. Everybody can complain, but data, as I've discovered, particularly in legal cases, is very useful in persuading judges and persuading agencies to do things they didn't want to do in the first place. Okay, so we don't have the data. There's limited recourse for the courts. I understand even malpractice suits are in disrepute now, and they're going down in their volume. And OCR has been, as was described earlier in the last session, been a victim of Parkinson's law in reverse. Now, Parkinson's law says that work expands to the resources and the time that's made available to do the work. Well, the Parkinson's law in reverse basically says that work will shrink to respond to the resources that are made available to it. And basically what we have now is, and I'm embarrassed to say it, and most people won't say it, but the emperor has no clothes. He's absolutely naked. Title VI is without any clothes. Okay, all right. Well, let me quickly go to the future because that has to do, I think, quite a bit with what the people here on the rest of the panel are going to be talking about. And I think one of the things that we have, you have to talk about strengths and opportunities and not weaknesses in terms of looking for a plan for how to put some clothes on Title VI. And I think we have an advantage now that we didn't have at the time of the passage of the law, is that there's universal acceptance of the goal of eliminating disparities. Everybody is talking a good game. They may not be walking the walk, but they're talking the talk. I mean, the AMA actually has given to the National Medical Association a formal apology and has invited them to participate in a commission to end racial and ethnic disparities. The American Hospital Association now has a group that's involved in getting data together and to doing all these things. We have bipartisan support of Healthy People 2000, 2010, and 2020. And major goal is to limit disparities. Now, all we need is the people in this room to put their heads together and figure out how to do it. And to take full advantage of all the emerging data that we have and all the research that's been described, and formulate guidelines for disparate impact and plans of correction. And I mean, legal suits may be going down, but if a provider doesn't comply with the standards that are being defined for disparate treatment, disparate outcomes, and I think they're putting themselves at risk of at least a malpractice suit of some kind, or at least embarrassment in terms of their local community. So I think the next thing that needs to happen is we've got to push that responsibility beyond the federal operating agencies to provider networks and health plans. And that, I think, and Sydney may talk a little bit about this, is what the Affordable Care Act gives us possibly the opportunity to do. And to push that responsibility, as some of these groups have already said, beyond the health providers to the broader community of the nation in terms of correcting these other kinds of inequities. Several people have used this quote. I would mention that the greatest disparities now are in the Midwest, the greatest degree of segregation in healthcare, the least disparities and the least segregation exists now in the South. And Cleveland has the highest degree of segregation as nursing homes of any metropolitan area in the country. And the Midwest has the highest segregation of any area in the country in terms of its hospitals. And all of that plays into these kinds of disparities. Okay, well, we have a lot of things in Cleveland in terms of world-class provider networks and a rich and successful history of grassroots organizing and lawyers committed to social justice. So I'll just leave on the same quote, only to remind you again, connecting the dots, that when Martin Luther King said this quote, he was speaking to the Medical Committee for Human Rights, and this was a recruitment speech for the people that were going to be the volunteers for the enforcement efforts that were to follow that later that year in terms of the Medicare program. Thank you.
Good afternoon. If you give us a minute, we'll get my PowerPoint up. Thank you. This little thingy, okay. All right. Good afternoon. I'm going to make a small correction to Professor's wonderful introduction to me. My name is Celeste Davis. I am the regional manager for HHS Office for Civil Rights, Region 5, Chicago. In that capacity, I serve as the Chief Civil Rights Enforcement Officer for the Secretary of HHS in a 5-state region in the Midwest. Those states include Illinois, Indiana, Ohio, Michigan, Wisconsin, and Minnesota. And while the emperor may not have had clothes in the beginning of Title VI enforcement, the present day, shall we say, empress likes to dress nicely. So we're going to start with just a really quick show of hands. Who knows what HHS Office for Civil Rights is and the work that we do? Quick show of hands. Okay, a little bit. The Office for Civil Rights, and let me move a little thing here. Okay, this is just an overview. We'll step 4. Okay, OCR's mission as HHS Civil Rights and Health Information Privacy Rights Law Enforcement Agency. We investigate complaints, we promulgate regulations, and we develop policy. We also provide technical assistance and public education to ensure understanding of and compliance with non-discrimination and health information privacy. OCR is structured. We have our headquarters in Washington, D.C., and we have 10 regional offices throughout the country. And as I mentioned, I'm the regional manager for Region 5. To do the work that OCR does, we currently employ 76 investigators nationwide. So, We are understaffed, and consequently, we do have to make very strategic decisions on how we investigate, when we investigate, and who we investigate. But contrary to the dismal reports that we've heard throughout the day, OCR is still quite alive, and we are doing some good work. This is actually a picture of President Lyndon B. Johnson 50 years ago when he signed Title VI into laws. Standing behind him was Martin Luther King. To give you a little bit of a past perspective on Title VI, in addition to what you've already heard from Professor Smith, Lyndon B. Johnson was a very shrewd negotiator, and it took quite a bit of maneuvering for him to get a Senate majority to approve the passage of Title VI, particularly those senators from the South. So, the great compromise, this is the real compromise, that was reached behind closed doors was this. These Southern senators would agree to pass Title VI, and LBJ at the time did not give Title VI any teeth. Did not give it really any real enforcement authority, nor was it adequately staffed. So, for example, no real enforcement authority. What I mean by that, for example, is Title VI has no independent subpoena power. So, during the course of an OCR investigation, we will typically ask the hospital or other healthcare provider to provide us with information. If they squawk and say no, we cannot issue a subpoena, and if they fail to comply with the subpoena, haul them into court and seek a court order for them to comply. Rather, we have a very cumbersome process where we have to submit a memo through our Office for General Counsel, which they have to review and approve, and send over to the Department of Justice. And it is actually the Justice Department that will go into court and request a court order. Title VI was also envisioned to be in a position where we would be able to get covered entities to come into voluntary compliance with the law. And this was going to be done through outreach and education. And the thought was, if they knew what they were supposed to be doing, they would be doing right. Again, that has not panned out as everyone expected. So let's say we're investigating a hospital that is not in compliance with Title VI. We will seek to bring them into voluntary compliance, which means if they are amenable, we can enter into what is called a voluntary resolution agreement with them, where they basically promise to do right. Again, if the terms of that agreement are breached, we have very few recourses. If the covered entity does not want to enter into a voluntary agreement, then OCR can issue something called letters of finding. And that's where we issue a formal notice that the covered entity has been found to be in violation with, for our purposes today, Title VI. If after we issue the LOF, the covered entity still refuses to come into compliance, our recourse is to go through, once again, a cumbersome process to present our case to an administrative law judge within HHS and seek to have the particular entity, quote unquote, disbarred. That means that they no longer will receive federal funding. Well, that is something that doesn't happen very often and is, in my personal estimation, not something that I want to do, because the federal funding that these institutions receive are meant to serve, in many respects, the underserved and the underrepresented populations that so desperately need help. So that brings us to kind of present day. I want to talk to you a little bit about Title VI, present day, the type of work that I and my office have been doing recently, which leaves me no doubt that Title VI race-based discrimination in the healthcare setting is still very much alive and well. I'm gonna just, move forward. We already know that based upon all the data that research shows that, racial groups and limited English proficient persons are disproportionately affected by barriers which prevent or decrease access to healthcare services, which I believe comes directly from the 1999 IOM study. Now, present day. All right. As we know, back in '64, Title VI was originally enacted to address what was then essentially segregated facilities, which usually provided substandard care. Now, interestingly enough, that was 50 years ago. Let me tell you what I've just been doing this past year in 2013, 2014. My office is currently investigating a case of a relatively large hospital hospital system. It is a hospital system that has two separate hospital campuses. One in a inner city urban area. It is considered a safety net charity hospital. So most of its clientele are typically Medicare, Medicaid patients. The other campus is in a relatively affluent suburb, and most of those patients there have quote-unquote insurance. In 1979, a group of concerned citizens filed a complaint in federal district court, which resulted in a consent decree being entered, where Office for Civil Rights, Region 5, we were appointed by the court to serve as the external third-party monitor. This case has been monitored for 33 years. And we have to approve any purchases of equipment or construction over $100,000. And we have to make a finding, is the allocation of resources between the two campuses equitable? The face of Title VI today, you will often see allocation of resources. Who, which campus, which area gets the money. The hospitals are going to allege or set forth as their legitimate, non-discriminatory reason for their decision that in order to remain competitive and stay profitable, they have to improve, they have to buy new equipment, or they have to put in new construction in the affluent area. So the more affluent hospital can remain competitive with the other hospitals in that particular area. In this case, that is exactly the reason that was set forth when the hospital brought to my office. They wanted to do $65.5 million in new construction, with the bulk of the money going to the other campus. Now, what's interesting is that these same three issues that were present in 1979 when this case was initially filed still exist today. And my office has made findings, and we are instructing that this hospital system provide a specific compliance plans to address these three issues: patient transportation, availability of specific medical services at both campuses, and executive board composition. When you do a Title VI investigation, look at who's on your board of directors, who is on your executive management team, the people who are making the decisions about how funding is allocated. Interview them, talk to them. You'll find out some very interesting things. We interviewed in this case, and I made a strategic decision. I was going to put all my staff, and this is how I was going to use my office. And we interviewed every board member. We requested minutes from every single solitary board meeting for the past 5 years, and we were able to rebut their legitimate, non-discriminatory reason. We need to stay competitive and make money. We were able to show pretext, because we found that over the last 5 years that you were still making the same decisions and allocating your funds in an inequitable way. So this case is, we are in the process of drafting up an agreement, and this is probably going to be one of the first significant Title VI race-based discrimination investigations that will come out from the federal government in quite some time. So we'll be able, I think, going forward to use this case as a model. The next thing that I want to just touch upon in my last few minutes, another ongoing issue, and I've opened 2 cases in 2013, last year, against 2 hospitals where African American nurses were prohibited from caring for a patient based upon the patient or the patient's relatives' request. Blatant, outright. There was a sign put up at the nursing station: no black nurses to work on X. Okay? In 1969, OCR issued Title VI guidance that required that hospital staff being assigned, or hospital staff assignments to patients should not be governed on the basis of race. I opened 2 cases from the same state last year. The interesting issue about staff assignment cases in the Title VI context is the patient and the hospital will argue privacy interests. And you have to balance the question of, because the patient is at the center of healthcare, Is it appropriate for a federally funded healthcare provider to enable and permit non-medical treatment decisions based upon race or color because of patient prejudice? Something to think about. Finally, I'm going to let Sydney talk about the Affordable Care Act, but I threw it in there. It is supposed to increase access to health care. It got off to a rocky start, but let's hope it gets better. The last thing that I really just want to touch upon is OCR has a medical education initiative, which we started, where we partnered with the National Consortium for Multicultural Education, and we created a medical school course called Stopping Discrimination Before It Starts: The Impact of Civil Rights Laws on Healthcare Disparities. This course is now a quote-unquote core required course in several medical schools across the country, including Emory, University of Colorado, to name a few. I just did a Title VI presentation 2 weeks ago, and I was introduced to the concept, is cultural competency enough? And I learned about cultural attunement and how medical professionals need to be more than culturally competent. They need to be attuned to their patients, their backgrounds, their needs. And so it is a responsibility of the healthcare providers to do what you need to do to get in sync. My closing thought, does access to healthcare equal better outcomes? Think about it.
Well, I'm going to modify my comments on the fly because of the deep respect I have for the co-panelists that just preceded me, because I was going to start off by telling you how sick and tired Title VI is. But I think I'm going to change that now. I have to say it a little differently. I'm going to speak quickly because of two things. One, a large part of my presentation relies on some of the work that you heard about in the earlier panel, and I have to say that I'm, again, humbled by another panelist and the work that she has done, as you'll see, on unconscious bias. My plan today is to talk about Title VI past, present, and future. I want to start by making a case that I'm trying to put forward in a recent book that I'm getting ready to publish, that bad law makes bad health. So before you spoke, I would have said one of the reasons we have health inequality and health injustice, I don't like the word disparities myself because it's just too neat and clean and sterile. But one of the reasons we have it is because we got bad law. All the work that you're doing, fabulous work. Fabulous work, but there are 74 or 5 of you doing it around the entire country. That feels slight to me, to say the least, right? And as well as I respect all that you're doing, it feels to me like Justice Scalia and Justice Thomas and his gang are really working really hard to reverse whatever work you come up with. So I'm going to still work really hard with you guys today talking about the fact that part of the reasons we have these health injustices is because our law is in trouble. And it needs reforming. And it will make a huge difference if we take that seriously. And I'm only going to talk about a little bit of problems. Some of the things that you said inspired me to think of more things. We need subpoena power. We need some other things. When I talk about health present, I'm going to speed through this material because I just want to make the point that the social scientists have told us convincingly that the real money in discrimination has nothing to do with overt bigotry, right? To the extent that Title VI is talking about overt bigotry, it is irrelevant. Because what's happening today is unconscious bias, unconscious racism, discrimination that people do not intend. It doesn't matter that they don't intend it. It is extremely harmful. And in fact, perhaps more invidious than the overt stuff I could see when I could see you coming down the street, right? And so if Title VI is at all serious about its mission to equality and its mission to justice, it must be reformed to affect and punish unconscious bias. And people are going to ask me how to do that. I do have an answer. I think it's worth a little bit of discussion. So the last part, Title VI future, will be my suggestion as to how we do that. So again, very fast, let me say that I could spend a whole afternoon just talking to you about how bad law makes bad health. And I'll just point out just a couple of things because I want to set the stage to say, yes, we have to do something about Title VI because it is one of the reasons that we have bad health. So the picture I'm showing you now has to do with the middle passage. We're all familiar with that, but are we familiar with the number of laws that enabled the disease to run rampant during the Middle Passage? Just to give you an example, Thomas R. Cobb, a successful Southern lawyer who wrote a defense of slavery called The Inquiry of Law into Negro Slavery, said that an act of British Parliament by statute restricted the number of people, slaves, who could be on that ship by tonnage, not by individuals, not by space, but by tonnage, right? And then assigned by statute the number of doctors who had to travel per ton, right? Okay, so this is an initial, in my view, example, and I could do lots more, of how the law directly impacts health disparities. This is evidenced, moreover, by the fact that these kinds of health disparities travel through generations. I can't spend a whole lot of time on it, but there is evidence that you and I embody the stress, embody the disease, and we pass it down on generations that come from discrimination and discriminatory laws. So I will tell you that when I was in utero and my mother was suffering the Jim Crow indignities, I felt it, I embodied it, and it is no surprise that my immune system, my allostatic load, and all the things that have to do with health disparities will continue to evince this as I and my children and my children's children continue until we do something to change it. We could go on. Property laws that gave land grants that permitted colonists to come in and bring the diseases that they bring on the native population. That was a way in which law facilitated disease, and disease was embodied disparately through minority populations. I would consider talking about immigration laws, vagrancy laws. Did you know that there was a Mexican Greaser Act to make sure that Mexicans did not live where whites lived, so that they lived in areas, zoning laws? I mean, we could go on for quite a while. I think I want to make the case, and I'm going to have to return to my statement that the law itself is sick and tired, and that's why we have a sick and tired population. So that's what I have to say about the past. Let me just add one other thing. There's another way in which law, I think, creates health disparities. I put up here a diagram of something that I use in my public health course, which is the social determinants of health. We could spend a lot of time talking about how law disparately distributes the determinants of good and poor health, right? How do you get a good job? How do you get food security? How do you get housing? How do you get access to education? The law itself is responsible for disparately distributing these resources, and as a result, surprise, surprise, the health outcomes are also disparately distributed. Lots of work to do here for lawyers that are socially minded. I'm just going to pass on these. Okay. How did I get to the future? Okay. I'm not there yet. That slide is out of place. Got more preaching to do, sorry. So this is the same slide. Hallelujah. We signed Title VI, and I'm going to try and be a little bit nicer. We signed Title VI 50 years ago. And as a result, I will say that in the past, we didn't see this scenario to desegregate hospitals, right? We didn't need to have hoses and marches and dogs and so forth to desegregate hospitals. That was an accomplishment. But lest we rest on our laurels, again, if you look at the data, bigotry is out of vogue. I heard somebody say during the break that lawyers have gone and taught the discriminators how to discriminate so that they can avoid this statute, right? So this statute does us no good anymore because discrimination happens a very different way today. So I want to talk about discrimination and how it happens today. You ended by saying, does access equal health? I want to say blank no. It does not. It cannot, because the access to the health care that we are busily trying to equalize is in its own right, I can't see, okay, it's in its own right unequal, all right? So I think equal access to discriminatory health care is not equal access and will not equalize health care or health outcomes, okay? That's why we see the data come out each year that shows us all you have to really get out of this bar graph is that the parts of health disparities that are improving are the little teeny black parts. The little teeny black area of these bar graphs are the measures by which access and quality of health care gaps are narrowing. The large blue sections describe measures by which health care disparities are unchanged. And the green areas describe measures by which health care quality is actually worsening when you look at racial and ethnic disparities, okay? So the message from these gaps is that access doesn't do it. Access doesn't give us or tell us the whole story. Why? Unconscious bias. Let me go to this very quickly because I have not got enough time. Back in 2003, when the Institute of Medicine published Unequal Treatment, they made a suggestion. It was a radical suggestion on which we have done very little work and made very few changes. And the suggestion was that physicians' own attitudes, biases, prejudices, and stereotypes actually might impact their treatment decisions. That was a tentative suggestion. Now, I understand from panel 2 that you got a lot of information to show that this is not so tentative anymore, that the preponderance of the evidence shows us that unconscious prejudices and biases do in fact and indeed influence the outcomes and the medical decision-making of our physician and provider population. So equal access to non-discriminatory care should be the objective of Title VI, I would argue. Let me go quickly through some of these. I heard that you already know about the implicit bias test. So the fact that we can measure people's spontaneous reactions and associations to racial, ethnic, and other pictures shows us how biased they are implicitly. So implicit bias works in a way that is subconscious. Moreover, it works in a way that the majority of Americans have either strong pro-white anti-black, strong pro-white anti-Hispanic, strong, lots of others, thin versus fat, male versus female, non-Muslim versus Muslim, strong biases against minorities, right? And moreover, the evidence has shown us, as I'm sure you have heard, that these biases more directly impact judgment and decision than explicit preferences. So what does that tell you? You can be as egalitarian and as progressive and as good a card-carrying liberal as you want to be. But the fact that you grew up in these United States and heard from the media and your grandparents and what you read on TV and the politicians stored social knowledge in your memory will inform your decisions, not your express preferences. It's been shown over and over again. Generally, I'll summarize some of those studies with respect to medicine. The Schulman study, please, if you know all of this, I apologize for repeating it, but Kevin Schulman told us that the decisions that cardiovascular cardiovascular internists made was directly impacted by race and gender when people who were posed as actors gave the exact same story about their medical history, the exact same data about their needs for medicine and so forth. They got different treatment based on race and ethnicity. With 5 minutes to go, I'm not going to go through the numbers. I'm just going to tell you that race and sex of a patient independently influences their physician's management of chest pain. That was connected by Alexander Green to implicit biases. The same decision-making bias is connected to the level of implicit bias that these physicians have. With 5 minutes to go, I'm just going to go to the outcome. The reason these little lines are so important is because what Green's study told us was that as implicit bias increased, that is, a physician's pro-white, anti-black attitudes increase, the likelihood of getting the treatment of choice decreased for blacks, and the likelihood of getting the treatment of choice increased for whites. That tells us that treatment is better for people if they're white and worse for people if they're black. Now, we need more studies in order to tell us what it means for Hispanics. We need more studies to tell us what it means in different professions, whether a pediatrician is any different than an internist and so forth and so on. But the lines are going the wrong way with respect to whether a treatment decision which yields a health outcome is going to be good or bad based on race. There are so many others. I had to apologize even before giving this presentation. I have about 10 slides that depend on Dr. Van Ryan's terrific work on perceptions of physicians and the fact that she has shown that a patient's race can influence providers' beliefs and expectations, so that providers believe lies. I'm sure you know this, right? I'm going to pick one because I have a teenager in trouble, which is why I'm going to run out of here really fast after this presentation. And I think about drug abuse, right? Black and white teenagers use drugs at almost the same level. They abuse drugs at almost the same level, right? Now, if I were Michelle Alexander, I'd be telling you about incarceration rates, right? But I'm standing here telling you that despite this, we have evidence that physicians will consistently misperceive this truth and assume that patients of color are misusing, diverting, and abusing drugs, and therefore undertreat their pain, change their treatment decisions, and this affects outcome. So where do I want to park? I really want to park, there's a lot of these studies, I'm going through them really fast. I want to park on a series of studies that I don't think is very well known, hasn't gotten the light of day, and I think it's very important from a legal perspective, and that is a series of studies that tell us that these unconscious biases, though they are incredibly harmful, are malleable. Like, you can do something about them. So the idea that they are unconscious, that they are parked in your memory, does not mean that they are inaccessible. Does not mean that one cannot be held accountable for doing something about them. And really, when I do this presentation, again, I'm going to put the bulk of my, especially if I follow Dr. Van Ryan, I'm going to put the bulk of my slides on this topic, right? Because what you need to know is that there is a lot of evidence, like 25 years worth of evidence, to tell us that we can, through stereotype negation training, that is not cultural competency training. That's not where you show up in a room and we tell you about how many people came over on the Mayflower and how culturally beautiful Mexican dresses are and ask you to be really sensitive about it. This is training that goes on for weeks because it has to undo habits. Just like bad driving habits can be trained, bad implicit bias habits can be trained. One of the studies that is my favorite was conducted in 1989 by psychologist Patricia Devine. She directed a series of 3 studies, and they concluded that intention with attention, with time, and deliberate effort, stereotype negation treatment can change unconscious preferences and teach people to override them. We need to hold institutions accountable for instituting this kind of change, since it is evident that this type of bias more directly impacts health outcomes than prejudice overtly does. Secondly, a series of studies has shown that promoting counter stereotypes, this could be as simple as the best studies actually are gender on these on counter stereotype promotion. When you have people of color from minority backgrounds in leadership, in administration, in charge, it changes the stereotypes that people use. It changes the information that they internalize, and it changes their behavior and their actual decision-making with respect to, in gender case, in respect to their treatment of the people that they are in charge of. This can be done in medicine. And lastly, my favorite of all has to do with what I call a type C intervention in my book. This is changing social motivation. I can't do the studies, but they are phenomenal. Here's what happens. We get a group of students and they take an express bias test, and we pick from those express bias tests the people who are actually avowed bigots, right? They rate on the scale of express bias very high, and they're anti-black, anti-minority. So they're bigots, and they admit it, and we know about them, right? We tell one group of them that their point of view is shared by the majority of their peers in college. We tell another group of them that their point of view is not shared. The behavior of the group who believe that they have consensus of those around them is markedly different from the behavior of the group who believe that they don't have consensus. What does that tell you? Here's my real message, and I'm going to start screaming here at this point. Law changes social norms. Yes. To the extent that we are serious about changing unconscious bias, we need to change the social norms that tolerate unconscious racism and tolerate racism in healthcare. That's why it's so important to make these changes in Title VI. Too much stuff to do here. So here's my solution. This is a little teeny tiny solution, quite frankly, to the size of the problem that I'm describing. And now that I've heard you, I'm going to go back and I'm going to write some more things that need to be done. I'm going to propose that we do at least 2 things with respect to Title VI. The first one is I want to expressly include unconscious bias in the disparate impact cause of action, right? I want to expressly do that by creating a negligence standard. Given the level of malleability evidence that there is, I want to hold institutions responsible for continuing to play host to this kind of unconscious racism without doing the things that social scientists tell us will work to dismantle this. And I think you can do this very easily. I got to stop, so can I go over one thing? Okay, so then the second thing I think you have to do is restore that private cause of action. Why? Because if you're going to spend 30 years trying to enforce somebody's consent agreement, I think we need a class action to move on up in here, right? And a class action that is peopled by those who have a stake in the outcome, right? U.S. versus Fordyce is my example, and I know there's a lot of problems with that cases, but that's what I think we ought to do. I think if we're serious about restoring justice under this statute, look how many slides I'm going through without saying anything because I'm supposed to stop, right? I think if we're serious about restoring justice, we have to at least start changing the laws that were intended to do that, to make them serious, give them some teeth, give them some money, give them some resources, and enforce them with some serious, serious deliberateness.
Okay, you made that hard. So, my name is Sydney Watson, and I'm a lawyer. I'm going to admit it in this room. And I've been struggling with Title VI for at least 30 years. I had my introduction to it a little more than a decade after the stories David Barton Smith tells in his book. I was a young legal services lawyer in New Orleans, one of the blackest cities in this country, a city in which the hospitals were clustered downtown, a city in which my clients had Medicaid cards, and a city in which none of the white hospitals, and that's what they were called then, would take their insurance. And I was a young lawyer, and I did what young lawyers do. And I filed a Title VI lawsuit. And do you know at the hospital, against 10 hospitals? That was a bad move. And what the hospital administrator said to me was, discriminate? Not us. It's not about race. it's about the money. The money made us do it. Either they didn't have insurance or Medicaid didn't pay enough. And if anything has happened in the last 30 years with this conversation, we now have the language to name that discrimination as structural discrimination. And I like the word discrimination rather than disparities. I learned as a young lawyer that saying, civil rights lawsuit, you're discriminating, makes people very angry and makes them stop listening, as we heard earlier. But I think it's important to claim what's happening. And my job today is to talk about the Affordable Care Act. And yes, I do have hope that our attempt to expand health insurance to almost all Americans, I worry about our undocumented immigrants, is that first step in dealing with this money issue that I've heard from you over and over today, that I don't have insurance or I have the wrong type of insurance. We have to begin with that structural problem, that structural discrimination, that structural barrier. And what happened in NFIB v. Sebelius, this decision that is now voluntary for the states to decide whether to expand Medicaid, has created another structural barrier. My congratulations to you here in Ohio. It was amazing to hear your representative talking about the decision that's been made here. You and 27 states are moving forward. We have 19 states in which nothing is happening, 5 in which there is a conversation. And if I put the slide up there, you would see that those 19 states where there is no conversation going on about Medicaid expansion make a straight line across the Old South, from Texas to Louisiana to Alabama to Mississippi to Georgia to Florida. The old slave-owning states where they're not expanding. Yes, the history of slavery is with us today. And there's also a history that David Barton Smith reminds us of the civil rights movement and grassroots movements and the importance of boots on the ground. There was a photo in the New York Times last week, I'm sure Dr. Jones saw it, of people being carried to jail from the Georgia General Assembly as they protested in favor of Medicaid expansion. In my own home state in Missouri, I wear today my Medicaid Coalition button. We have hundreds of grassroots groups across the state who we are learning to work together, because the expansion of Medicaid will not be about saving our hospitals or creating jobs or the economic opportunities. It will be about morality, what's right, what's just, what we do for the least, we do for all of us. But you know, I'm gonna move on, because I hope that every state will expand Medicaid, and there are other pieces. The conversation we heard earlier with Vernellia, we begin by covering everyone, but we have to also be attentive to discrimination, disparities, and inequalities, because they will be there. And there are gap fillers for Title VI in the Affordable Care Act. I want to leave you with some numbers. Section 4302 of the Affordable Care Act is a new data collection provision, which requires all health care providers to keep data by race, ethnicity, and primary language. This is crucial and important data that we have never had. You as researchers, we as lawyers, those of you as community advocates, will be able to see the hard numbers of who our hospitals are admitting and who they're not, who our specialty practices are treating and who they are not, who our new marketplace insurance plans are enrolling and who they are not. Data by which we can shame, by which we can blame, by which we can file Title VI complaints, and by which we can file lawsuits. Because I also want to give you another number, 1557, a new civil rights remedy in the Affordable Care Act. the broadest and only health care anti-discrimination provision we have ever had in this country. And how many of you have heard of Section 1557 before today? Yeah, the unsung civil rights story. So 5 things to remember about 1557. Number 1, it leaves in place Title VI. Whether you believe it's good or bad, ugly or beautiful, it remains in place, and everything you've heard today about it remains. Number 2, Section 1557 prohibits both disparate impact and intentional discrimination, facially neutral practices that have a disproportionate racial impact, and also that unconscious bias that may be hard to prove, but Dana's going to come up with a theory by which we do it. Number 3, Section 1557 allows for that private right of action for the individual, the class, the aggrieved party to file a lawsuit, some for equitable relief, that injunction stop doing it, and also for damages in situations of intentional discrimination. And this is so important. Administrative agencies and good people can do a lot, but it's not enough. We need the boots on the ground. There is more than arguably this private right of action to sue for unconscious discrimination that no longer exists within Title VI. Here is my Howard Law Review article where I explain the details of why this exists. I will send you to that. I mail it out to young public interest lawyers and legal services lawyers every week. Number 4, Section 1557 protects many more groups than does Title VI. It prohibits discrimination based upon race, national origin, and language, just as Title VI does, but it also reaches age discrimination, disability discrimination, and sex discrimination, including sex discrimination based upon gender identity and failure to conform to sexual stereotypes. This is the first time we have had a federal law prohibiting sex discrimination in health care programs. Title VI did not reach sex discrimination. We only had Title VII, which reached employer-sponsored health insurance. This is huge. This is a big deal. Number 5, Section 1557 reaches a whole array of healthcare providers and healthcare entities that Title VI has never covered. Title VI covers all those hospitals and nursing homes that receive federal financial assistance. But that definition of federal financial assistance is limited in Title VI. And Title VI has never reached private health insurers. I'll say it again. Private health insurers, our way of financing most of the health care in this country. So what does this mean on the ground? What does it mean in practice? Number 1, those new private plans that are being sold in the marketplace, they are all subject to the anti-discrimination provisions in Section 1557. Are they failing to include African American doctors and African American providers? We have a legal tool. Are they setting up networks that avoid minority neighborhoods as a way of discouraging minority patients from enrolling them? We have a tool to ask those questions and address it. Number 2, Section 1557 reaches private providers who accept and participate in any of these new market plans or in Medicare. The statute, the anti-discrimination remedy follows the money. When these marketplace plans accept the new premium tax credits, that's why they become subject to this anti-discrimination provision. And when they then reimburse physicians home health agencies, rehab hospitals, pharmacies that often turn away our African American men because they think they're drug seekers. The civil rights remedy follows the money. Suddenly, we have a civil rights remedy that is much, much broader than Title VI. 3, it applies to the new marketplace plans, whether it's a state marketplace or a federal marketplace like you have here in Ohio. And if you're like us in Missouri, we've been using a lot of application counselors and navigators to help people get enrolled. But this anti-discrimination provision means we need to stay attuned to whether these navigators are going into our minority neighborhoods, whether they are culturally attuned. Again, attuned to ask the questions about disparities, about discrimination, about access. And finally, Section 1557 applies to all programs that are health programs that are administered by the federal government. That includes NIH research, FDA programs, the Federal Employees Health Insurance Program, and the new co-ops that have been created that some states have. That's the law. What's happening with it? We've had the first lawsuit filed under Section 1557, and I'm happy to say it's come to a successful conclusion in the last couple of weeks. The case out of Louisiana is East versus Blue Cross Blue Shield of Louisiana. Anthem Blue Cross led the way in Louisiana in refusing to accept Ryan White payments to help people pay for their health insurance premiums through the marketplace. They were sued, alleging a violation of 1557 that it discriminated on the basis of disability. The plaintiffs alleged both disparate impact discrimination and intentional discrimination. The federal judge issued a temporary restraining order, finding that there was a likelihood of success on the merits of Section 1557's anti-discrimination provision. For the lawyers in the room, there wasn't a great deal of detail about that analysis, but a win is a win. And about a week ago, Anthem Blue Cross and the other insurers who are following them agreed to begin paying, accepting those payments, and the case has been settled at least through this year. My other good news is that OCR has a website open and available where it is accepting complaints filed pursuant to 1557. We know there has at least been 4 complaints of sex discrimination already been filed that are being handled. They are open for business.
One in my district.
Yes. And on the bad news front, or the not so good news front, you hadn't heard about Section 1557. Secretary of HHS has tasks to OCR writing the regulations, which are authorized by the statute, but unlike many other sections of the Affordable Care Act, there is no time limit for writing those regulations. There are no time limits for writing those regulations, and they have not been prioritized. Very disappointed in that. All we have from the Office of Civil Rights is a request for information that was issued last fall. The time has closed for that. I will say that over 160 organizations and individuals submitted comments. And many of those comments were in response to a question: tell me about your experiences of discrimination in healthcare. I do hope that what we will see from the Office of Civil Rights is a very robust description of some of the problems and barriers that you have talked about here today. My concern is that the Office of Civil Rights also asked a strange question in its request for information, which is, what do you think the scope of this new civil rights remedy should be? And I think the scope is very clear from the statutory language, and I hope that the Office of Civil Rights will be honest to that statutory language. What do I think that we can do about Section 1557? This is an opportunity to revisit that grassroots movement that David Barton Smith talks about from the beginnings of Title VI. This is an opportunity for our community organizations, our community-based providers, us as individuals, to begin sharing this information, to begin filing these complaints, to begin talking to young public interest lawyers about this new remedy. This, like the Medicaid expansion debate, needs to be a bottom-up new struggle for social justice and equality, into discrimination, disparities, and difference. Thank you.
I'd like to thank the panelists. Tomorrow we will have more time. Unfortunately, there is a lecture that is being webcast from this same room very shortly. So we're not going to have time to ask the panelists questions, but please come back tomorrow and we will continue this discussion, particularly as we talk about crafting solutions. So thank you for being here today. We will have more time tomorrow, and I look forward to seeing you. Thank you.